Hi, everyone, and welcome to February's NICER Monthly Patient Case Conference. Today we have NICER Institutional Site WashU. I'm admitting a few more people. I'm going to give the floor to Dr. Eldem, who will be presenting today. Thank you so much.
Thank you very much, everyone, for joining, and thank you, NICER, for giving me this opportunity to present our case today. I will talk about our body's immune dance with Epstein-Barr virus. My objectives will be to identify the immune cytopenia in pediatric AYA patients, define the chronic active EBV disease, and discuss about the management of those patients. Our case story started with a hematology visit about 1.5 years ago. This is a 19-year-old boy adopted from Guatemala with already known diagnosis of a metabolic disorder called ornithine aminotransferase deficiency, who presented with complaints of fatigue, shortness of breath, and prolonged nose bleeding for the last couple of months. On initial evaluation, the labs were significant for mild microcytic anemia with robust reticulocyte response and significant thrombocytopenia. His direct Coombs test was positive for IgG, and LDH, uric acid, CMP evaluation were within normal limits. Peripheral smear did not show any signs of hemolysis or blast, and he was admitted for further evaluation. The past medical history was significant for recurrent acute otitis media, but outside of that, since infancy, there was no hospitalization or any recurrent infection history. The OAT deficiency, as a reminder, is an inborn error of ornithine metabolism. The patient got the diagnosis around 14 years old when presented with blurred vision to ophthalmology and diagnosed with a gyrate atrophy of the choroid and retina. This disease can cause rarely proximal muscle weakness, and those patients have elevated ornithine levels, which was the case in our patient. So the initial bone marrow biopsy was looking actually unremarkable on the first sight, slightly hypercellular bone marrow for his age, with multilineage hematopoiesis and mild megakaryocytic hyperplasia, which could be seen at the setting of immune-mediated thrombocytopenia. There was no increase in blast. The flow cytometry was a little bit interesting, showing some atypical CD8 effector positive T cell population, and there was the ratio reversed with CD8 cells increased. The initial cytogenetics panel had a culture failure, was not reported, but the MDS and ALL FISH panel showed significant levels of presence of tetraploidy signal patterns with low trisomy, which could be observed at the setting of the hyperinflammatory and marrow stimulation, where those probes can stick to each other and show the ploidy pattern. So the immunology and rheumatology teams were also consulted, and the workup showed normal immunoglobulin panel, but remarkable for positive lupus anticoagulant, positive ENA, and positive anti-chromatin antibody, and high titers of ANA, 5 and 5,000, which was kind of looking like more like a secondary ITP or immune-mediated cytopenia picture at the first sight. So the patient was considered as Evans syndrome with more prominent component of ITP, and received IVIG therapy, started on steroids. Eventually, a couple of months later, because the ITP was still persistent, patient required rituximab infusions, 4 doses, to control his cytopenia. And eventually, the immune cytopenia was resolved around 6 months after initial diagnosis. But the story didn't finish here. Here you can see the trajectory. The patient initially started with immune-mediated cytopenia. And then about a year later, sorry, this should be July 2025, about a half year later, we started to follow this patient in our immune cytopenia clinic, joint clinic with immunology, Dr. Megan Cooper. And the platelet count was still low, 30,000 at that time, but noted to see some elevated liver transaminases. 5 to 6 times of the normal level. So we consulted the GI for this. Meanwhile, while pending on the GI workup, the patient was admitted for cellulitis, which was odd for his case, as he has no recurrent bacterial infections outside of AOM in the past. So the GI was also consulted at that time, and the EBV PCR titers was sent because of transaminitis and found to have 10,000 copies in units per ml. About 2 months later, the cellulitis was resolved, but now this time the patient presented with severe chest pain and abdominal pain. And at that moment, the plasma EBV titer was detected as 400,000. The platelet count in cytopenia was completely resolved at that time, and we were at almost 8 to 9 months after initial diagnosis of Evans syndrome. So about a month later, the patient this time presented with cough and rash over his knee and significant joint pain. During that hospitalization, the patient noted to have significant weight loss, about 10 pounds within the last 6 months. So further workup initiated with imaging included chest, abdomen, pelvic CT that revealed, I'll show in a second, hepatosplenomegaly and also some reactive lymph nodes in the mediastinum and the neck. So we get together with ID, rheumatology, immunology, GI teams, and hematology together and discuss what could be going on here. And our preliminary working diagnosis was in a lymphoproliferative process and the entity called chronic active EBV, as the patient's EBV titers are higher than expected, even at the setting of an autoimmune disorder. Repeat bone marrow biopsy, liver biopsy, and whole genome sequencing were planned. The patient treated for community-acquired pneumonia and supportive treatment for parainfluenza infection. So while we're planning that workup, during the same month, the patient admitted for hematochezia and reporting about 2 to 3 bowel movements, loose stools, and seeing blood one time in the stool, and also worsening cough. And so the pulmonary function test and bronchoalveolar performed did not reveal inflammatory changes or significant infectious etiology other than community-acquired pneumonia. And here is the summary of the diagnostic workup. We know that the patient about a year ago already had EBV, VCA, IgG positive titers. So this was a past infection. And in order to identify which cells are infected with the EBV, we sent to Cincinnati peripheral blood flow cytometer cell sorted PCR and showed that the T cells were the main cells infected with the EBV. The copies were about 280,000 and followed by NK cells and then B cells. And the whole blood PCR, sometimes this might be difficult to find a lab for that. Need to specify, for instance, in our laboratory, this was plasma-based EBV PCR, but the whole blood PCR showed 89 million copies. And here on the right-hand side, you can see how the patient EBV copies were fluctuating. And at the time of the admission for lung infection and respiratory symptoms and hematochezia, actually, patient's plasma EBV PCR was not that much high. The bone marrow biopsy was repeated and mildly hypocellular at that time, but immunohistochemistry staining showed scattered T cells, occasional B cells with EBER staining positive, and kind of we couldn't do the co-staining, but at the similar pattern, the EBER in CD T cell, 3 T cell positivity. Again, there was low-level tetraploidy signal pattern without any clonal single clone process. We did send T cell receptor gene rearrangement that showed polyclonal for T cell gamma rearrangement that was consistent more inflammatory process rather than monoclonal lymphoproliferative disease. The other cytokine panel and inflammatory panel showed mild to moderately increased ferritin, CXCL9, soluble interleukin 2 receptor, as you could see, and interleukin 18 levels. The liver biopsy showed stage 2 periportal fibrosis, and again, there was more predominant T cell population, and that were similarly stained with the EBER as well, which is EBV RNA stain, that also consider that those T cells were infected with the EBV. The MRCP showed a moderate hepatic steatosis, hepatosplenomegaly, and small wedge-shaped cortical areas, diffusion restriction on both kidneys. But the patient didn't have any kidney infection or renal vein thrombosis at that point. The echo showed normal left ventricle function. And as I said, we did extensive workup for microbiology, for bacterial, other viral or fungal diseases. They were negative outside of parainfluenza infection and community-acquired pneumonia. So even we were trying to treat for the underlying infection, the patient respiratory distress got worse, and he started to fail the 6-minute walk test. He couldn't complete that even at 1 minute. And the chest CT here, you can see on the right-hand side, kind of ground glass opacities, honeycomb appearance, considering more like an interstitial lung disease, but it was not reported in the imaging. And the bronchoalveolar lavage showed abundant nuclear leukocytes. EBV PCR was positive, but like 95% of the population carries in their air droplets. And the PFDD also studies showed decreased forced expiratory volume and then VVC that was more persistent with the restrictive pattern as with the ratio of V1 and VVC were being normal. And the interstitial pneumonitis considered at that time, which doesn't fit the picture of parainfluenza infection, but more considering EBV, chronic active EBV might be causing this etiology. Symbicort and systemic steroids started with that within a couple of weeks, the patient had improved respiratory distress and 6-minute walk test. So the whole genome sequencing showed interesting findings. We confirmed that the patient had OAT homozygous VUS variants, but this should be pathogenic given the patient presentation. And also a gene called ZNFX1 homozygosity for another VUS variants. Now I will pause here about our case And happy to take any questions about the case, but I will move forward with chronic active EBV disease.
Hi, can you hear me?
Yes.
Sorry. Did your patient have a type 1 interferon score by any chance?
No, not at that point.
Okay, interesting. It's just something associated with the CNFX1 loss of function. That's why I was asking. Thanks.
Okay. Mhm. Later on, I was showed we sent the cytokine full panel. Interferon gamma was elevated, but not at that point. It didn't have the full panel.
And that was like treatment naive.
Treatment naive, yeah.
Thanks.
Those levels, CXCL9 levels, interleukin 2 receptor treatment naive. Thank you. So now we'll move forward with Epstein-Barr virus infection. So it is a very interesting virus. It's a gamma herpes virus family, double-stranded DNA virus. And it's the first identified human tumor virus in 1960s, isolated initially in Burkitt lymphoma patients. EBV infects about 95% of the world's population, and most of us has it as a asymptomatic primary infection and stays as a latency and is shed in the saliva of healthy individuals. And there it causes this famous infectious mononucleosis symptoms. It has a lifelong persistence in the human host by infected, I would like to emphasize B cells mainly here, and residing in memory B cells in healthy individuals. The expression of the EBV virus changes during lytic replication and latency. And the lytic replication is the time where we start to see the infectious mononucleosis symptoms. And this is the dance of human body with the EBV. The immune response is activated against our innate immune system and adaptive immune responses. So both pathogen recognition receptors, pathogen associated molecular pattern are the sensors and that activates NK cells, gamma delta T cells. Meanwhile, B cells and epithelial cells are infected, and also CD8 effector T cells will be important to eliminate or cause the latency stage in EBV infection. Meanwhile, EBV also invades our immune system by blocking interferon signaling and inflammasome formation, and also targeting the DNA sensing pathways. So it really masters at evading the adaptive immune responses. The EBV also associated with oncogenesis, and it's stratified based on their latent gene expression programs, and latency 1 stage associated with Burkitt and gastric carcinoma, latency 2 stage, which is also seen in EBV associated lymphoproliferative disorders. There is moderate EBV viral gene expression. And latency 3 stage is the one that we observe in immunocompromised or HIV infected patients, lymphomas, and post-transplant lymphoproliferative disorder. And this is a schema showing how EBV modulates the infected cell, in epithelial cells or a B cell infection. And I want to remind here, during B cell infection, EBV can bind a complement receptor CD21, which is also expressed on T cells and may utilize to infect T cells as well as epithelial and B cells. So EBV can induce genomic instability and can cause oncogenesis. Using this genomic instability, it can block immune-mediated killing and dysregulate also cell metabolism by inducing inflammatory cytokines and growth factors. It also prevents apoptosis and induce angiogenesis by promoting metastasis. So what about T and K cell infection? Interestingly, this is more geographic disease and seen particularly in Asia, Central and South America, and characterized by type 2 EBV latency that I just showed, with specific expression of patterns by EBV molecular expression there. And there are four categories associated with that: extranodal NK T cell lymphoma, systemic EBV associated T cell lymphoma, aggressive NK cell leukemia, and persistent EBV infection of NK cells or T cells that can cause either chronic EBV or EBV associated HLH. What is chronic active EBV? It's a severe and life-threatening condition because of persistent EBV infection in the body, causing clonal expansion of infected T or NK cells, leading to systemic inflammation, organ damage, and constant infectious mononucleosis symptoms can be complicated by HLH and eventually lymphoproliferative process. We still don't know why there is a geographic predisposition to these disease. And I will show in a second. Japanese are the one who kind of established the consensus guideline in the diagnosis, for instance. Our patient was from Guatemala. Again, that part of America was more predominant to see chronic active EBV. It might be related to the receptor that on the T cells that EBV can enter. It was first identified in 1980s during a Japanese survey actually as a childhood disease. And median age was 11 years old in that survey, and the prognosis was worse in the older patients. WHO and ICC in 2022 recognized this as one of the EBV positive TNK cell lymphoproliferative disorder. And what are the symptoms of chronic active EBV in US and Japan? You can see some actually differences. Lymphadenopathy is more common in US patients. Organomegaly similar. Our patient had that. Fever, our patient also had that during the last admission, but it's more prominent in the Japanese population. Hepatitis, our patient have that, again, more common in Japan. Cytopenias observed, hypogammaglobulinemia, hepatomegaly, hemophagocytosis, and interstitial pneumonia, which our patient has and more reported in United States. CNS disease, neuropathy, rash, hypersensitivity to mosquito bite, and hydrovaccinoforme, which is a separate disorder than this entity. They have specific skin lesions. Our patient has severe mosquito bite allergy. Actually, one of the rashes during over the knee was, I think, was associated with a mosquito bite, as he had a lot of outdoor activities at that point. And so the fever, lymphadenopathy, organomegaly, it can cause a severe HLH-like picture. Peptic ulcer, our patient has severe stomach pain, if you remember, but also colitis picture that can cause that. Vasculitis, coronary artery aneurysms, and death associated that reported. Uveitis, liver failure, again, reported also in the context of HLH-like picture. So those experience of the symptoms could fluctuate in a patient. There could be times the patient's immune system get over it, but sometimes the symptoms could worsen rapidly and cause mortality if no intervention has been made. So far, no single genetic defect has been associated with large proportion of chronic active EBV disease. This nice blood paper showed that actually the EBV cells infect not only NKT cells in this entity, but it's a clonal hematopoietic stem cell issue. And here you can see the percentages. It's more predominant in the mature peripheral blood cells eventually, but even hematopoietic stem cell progenitor level showed EBV infection. And probably the EBV itself alters the immune response and then triggers this proliferative process, also creating autoimmune picture that our patient have the presentation of it. Little is known about the mechanism why EBV infected T and K cells are not removed by cytotoxic T cells. Probably those effector T cells are infected by EBV and blocked to have a response for EBV elimination. And this is the criteria that was published recently in 2023. So four criteria needs to be met: persistent infectious mononucleosis-like symptoms over 3 months. This shouldn't be an acute infection. And we already shown in our patient that the patient had a past EBV infection. Detection of increased EBV genomes in the peripheral blood, and this should be from the whole blood samples, about 10,000 copies. And affected tissues were already shown in the both bone marrow and the liver biopsy in our patient. The third one was detection of EBV infection, mainly in the T or NK cells. So this is not a B cell disease, but more T or NK cell disease, and a chronic illness that cannot be explained by other known etiology at the time of the diagnosis. I think I might challenge the last criteria here, as so if we identify underlying inborn errors of metabolism that leads to the chronic active EBV, that fourth criteria might be challenged. So what is the treatment? The only currently curative option is allogeneic hematopoietic stem cell transplant. So the chemotherapy has been trialed by multiple centers before, especially at the setting of lymphoproliferative disease. It can reduce the activity in chronic active EBV, but should be considered as a bridging therapy because it's not curative. It will not impact the EBV viral loads, and the overall survival rate for patients significantly decreases if it's not bridged with a transplant. But for sure, we know that if the active disease is controlled before heading to the transplant, those patients have the best outcome. So the other treatments that were trialed in the past were antiviral therapy, interferon therapy, IVIG, conventional chemotherapy, autologous cytotoxic T cells, cyclosporin A, steroids, rituximab, if it's mainly B cell dominant, bortezomib, and ganciclovir. These are all created, and I discussed with multiple centers when we're investigating our patient, including NIH and Cincinnati. Those created transient reductions in the systemic symptoms without actual control of the disease. So also I want to remind you the plasma EBV DNA load can be associated with the disease activity, but the whole blood itself is more important. I want to remind in our patient especially in significant lung involvement of chronic active EBV, his EBV plasma PCR was lower than 10,000. And this is kind of the literature summary showing the trialed medications in the past. And you can see if it was only steroids and chemotherapy, the complete remission rate was 17% during that observation without any virological remission. CHOP is another lymphoma chemotherapy protocol, complete remission 13%, and 3-year overall survival was 0% in that 52 patient group who only received 20 of them only received chemotherapy. There is a method called cooling and then cytoreduction and then eventually transplant. This method has about 3-year overall survival of 87%. And then Dr. Douglas Saldana reported in group in 2022 outside of Asia, this is the US study, the pre-transplant response was pretty variable. Some people observed, some people use rituximab, steroids, ruxolitinib, PD-L1 checkpoint inhibitors, anakinra, bortezomib. So variety of therapies with variable response, but the patients who received transplant had 2 years overall survival of 55% versus non-transplant, it was 25%. And here they showed that pre-transplant viral load less than 10,000 did not show any survival advantage. Control of hyperinflammation and maintaining good organ function was the most essential before the transplant. And the T-cell eradication therapies actually should be avoided before the transplant as it can have detrimental consequences. Again, this was recently published at TCT, and they were showing cord transplant with a modified myeloablative regimen with a GVHD prophylaxis, cyclosporin, and MMF. And they showed 3-year overall survival in this pediatric cohort, about 87%. But I want to emphasize the patient age group looks younger here, younger than 8 years old. And this was the US cohort, 57 patients followed over 1.5 years. 8 patients didn't receive transplant, and 6 of them died due to persistent disease. So the take-home message is prepare patients transplant as soon as possible and try to optimize, preserve the organ function and control the inflammation. Here, you can see in the diagram, the patients who didn't receive transplant had more mortality. And also, having a lymphoma at the initial diagnosis also impacted the survival. This was a recent abstract presented at ASCO last year. This was the largest global cohort from 9 countries, 763 cases, and this was the largest that I was able to find in the literature. 98% of them from East Asia and 2% from US. Median age of diagnosis was 18 years. That is consistent with our patient. Now they're working on a new classification by using the tissue systems involved at the initial presentation. And GI involvement seems like the poorest prognosis, necessitating the early intervention. And data from about 400 patients show that transplant, again, as the only curative option, significantly improving survival rates. For the high-risk patients, and here they if they're unable to go allogeneic transplant, they use anti-PD-1 therapy that showed potential as an adjunctive therapy without requiring transplant. And I know Dr. Ashish Kumar from Cincinnati also reported a series. Those patients had lymphoma as part of their chronic active EBV and seem to be under control with immune checkpoint inhibitors. But also, I want to emphasize here, those medications also have autoimmune side effects, so need to be used carefully in this setting. Also, if we're preparing a patient for the transplant, their clearance from the body takes a couple of months, so it could kind of push back the transplant plans. But here in this abstract, low-risk patients were monitored and treated with, if needed, immune checkpoint inhibitors. High-risk patients received either transplant or anti-PD-1 therapy, and very high-risk patients received allogeneic transplant. And this is kind of a summary slide showing the other therapies. There was a How I Treat Blood paper showing bortezomib against cyclovir. But again, I couldn't find a good case series with this regimen, and there were anecdotal human responses. That's why we didn't choose this regimen, proteasome inhibitor against cyclovir. Technically, it could work, but it was not the ultimate regimen to control the disease. Again, immune checkpoint inhibitors block the signal that prevents the activation of T cells against cancerous cells. But again, we need those T cells to fight against the EBV itself. There is more data, I think, coming for those agents. Ruxolitinib. Okay, this was interesting, and actually, I landed on this agent eventually for our patients. There is a paper reported constitutively activated STAT3 signaling in those EBV infected T and NK cell lines and patient peripheral blood mononuclear cells from CAEBV. So the ruxolitinib suppressed the viable EBV positive T and NK cell lines and was showed in this paper. And there was also a retrospective study published in 2021 that out of 9 patients, 7 of them showed controlled inflammatory symptoms. This is not to cure the disease, but to control the inflammatory symptoms, that they became afebrile and their splenomegaly improved. But again, there was no decrease in the EBV PCR. It was only to control the active inflammation. And coming back to the other interesting finding, ZNFX1. This is a type 1 interferon, as mentioned before, associated with inborn areas of type 1 interferon immunity and can cause increased inflammation and susceptibility to viral infections if there is a mutation in ZNFX1. And it's very conserved, highly conserved and interferon stimulated double-strand RNA sensor in mice. The mutations should be homozygous or compound heterozygous, and they're identified in humans as well. It's associated with poor clearance of viral infections by monocytes. It causes necrotizing multi-system inflammatory disease and characterized by cytopenia, hepatitis, kidney disease, TMA, lung disease, neurological involvement. You can see everything that we can observe in chronic active EBV. And again, it causes HLH-like disease eventually. Spontaneous remission rarely can happen, but those patients require transplant as well. And here you can see our patient had around this 6th zinc finger where the mutation was. And it was in a conserved area. The protein was 469. Valine was reported in the literature. That patient had back-to-back viral infections during infancy and then had a very detrimental course. Our patient had valine to isoleucine, so it looks less detrimental, but I still hypothesize that it may cause instability in the protein function at the setting of, maybe EBV infection. In summary, Our patient diagnosed with chronic active EBV disorder due to persistent infectious mononucleosis symptoms and with fulfilled the criteria with fever, weight loss, immune cytopenia, lupus-like disease, autoimmune disease, interstitial lung disease. So I didn't mention, but our patient, while we were prepping for the transplant, developed also pericardial effusion. That was not present there and required hospitalization for that, eventually controlled with more steroids. I'll mention the treatment in a second. Hepatitis, gastritis, colitis, some lymphoproliferation as evident by organomegaly, but there was no single clone lymphoma evolution, sensitivity to mosquito bites, and peripheral cell-sorted PCR showing T cell predominant EBV, and liver biopsy showed tissue EBR positivity with diffuse T cell invasion. So as a treatment, how did we manage that? First of all, we tried to allow his body also to deal with the EBV because um, spontaneous remission also reported in the literature. But given the end organ damage, we also started, especially after interstitial lung disease, the steroid course, and it has a long taper for this patient. We started to prepare him for the transplant, but meanwhile, also obtained the compassionate use for JAK inhibitor, especially after I consulted NIH and seeing those reports. I also read that for ZNFX1 deficiency, JAK inhibitors can be helpful. The other therapies, the pulmonology get involved, so Symbicort, Montelukast started preventive antibiotics, well as cyclovir, pentamidine, azithromycin, and also for peptic ulcer prophylaxis, lansoprazole. Rheumatology started him on hydroxychloroquine, but then eventually we needed to stop because of his eye exam started to show some toxic maculopathy. And this is the cytokine panel showing treatment naive, but also when he showed evolution of the disease, but the lung, and eventually back in December with pericardial effusion, because he was still showing CXCL9 elevation and also a soluble interleukin-2 receptor was increased under treatment with ruxolitinib. We decided to start him on emapalumab therapy, and he started to receive this weekly basis until his transplant. And happily, he just received his allogeneic mud hematopoietic stem cell transplant. He just had his neutrophil engraftment pending on the full engraftment, and his current EBV PCR is undetectable. So in summary, chronic active EBV is an inflammatory clonal TNK cell disease characterized by persistent symptoms of infectious mononucleosis. The clinical presentation could be very heterogeneous from milder to life-threatening systemic symptoms. In our case, it started with immune-mediated cytopenia and then evolved to hepatitis, colitis, interstitial lung disease, and pericardial effusion. The predisposing factors for clonal EBV and why EBV-infected TNK cells are not removed by cytotoxic T cells are not clear. As I said, there is no one single gene disorder for this, but in our case, we had maybe an explanation with the ZNFX1 deficiency, but we couldn't prove that. Hematopoietic stem cell transplant is the only curative therapy, and with pre-transplant good control of inflammation and preserved organ function. Currently, there is no consensus on pre-transplant treatment per disease severity. I would like to thank you for listening, and also all of the hospital departments who was involved, and Dr. Ben Narsky from the transplant team, and also from NIH, Dr. Jeff Cohen, for his suggestions about the case. And happy to take any questions. Thank you.
Would you mind? I'm sorry, this is Emma from Tampa. Would you mind going back to the part where I'm sorry, had to come late, but I don't know at which point you decide this is chronic active EBV. Is it PCR positive or PCR positive at a certain viral load? I'm sorry, I missed that
Sure.
part.
Yeah, thank you for this question. It was very challenging, I would say, to be honest. We were so biased. Oh, this is lupus-like picture. ANA was increased. Evans syndrome was initial presentation, but the patient started to have liver transaminitis. And
Mhm.
then that prompted more viral workup that showed here with the viral workup, EBV PCR above 10,000 especially. Less than 10,000 reported in some autoimmune diseases, but persistently above that prompted further workup.
Okay, so would you say it's a combination of the clinical and the viral load? If they had severe, like same clinical picture, but a viral load of 5,000, then you wouldn't have gone down this path?
I think if I have significant clinical suspicion, I would still send the peripheral blood cell sorted EBV PCR because what our lab has the plasma PCR. This is not the whole blood. So and either sending to whole blood sample to specific lab and sending cell sorted DNA because we need to show that this is T and K cell infection of EBV.
Okay, that makes sense. Thank you.
Thank you. Yes, Dr. Grunewald.
Excellent presentation, very interesting, and kudos to NICER for arranging this dance. And following on the previous question, I think that there is, especially in immune compromised individuals, there's a different balance where some of them are able to somehow control EBV. It's not same undetectable as it would be in most of us with a normal competent immune system. But I haven't really come across that concept in the literature. And I'm not sure that you emphasize that, although you mentioned that you don't respond to a level, but to the clinical features. Is that correct? Would you?
Yeah, that's very, very interesting and a very important point. So, first of all, maybe you're right. Most of our immune competent patients, because we can develop infectious mononucleosis, especially young adult life. And it has a very severe symptom, but some of us not able to get rid of it and or get rid of it at some point cause latency, but the virus enters to the lytic phase again and causing this picture. And there are a lot of immune dance between our immune system and EBV's invasion to our effector cells. If the T cells were not affected, and if this patient seems immune competent before, I think he will get over it. But here, once the effector T cells who are essential for EBV latency are infected, so that was kind of the detrimental part. But also there is a report of clonal process and why that clone hematopoietic stem cell get infected is again unanswered question. That also, supports why the transplant is helping, but there is a chance of recurrence after transplant as well, unfortunately, I need to say. That's why we use the myeloablative regimen for him and modified myeloablative. And also the donor should be EBV positive before, preferably, because so that those memory cells already aware of and managed to deal with EBV before. But recurrences are reported that makes me think that there might be some IEI component that we still couldn't figure out.
Thank you.
Thank you.
Dr. Eldem, there is something in the chat here. Dr. Kristen Ebens, transplant bias. How would you describe your patient's disease status at time of transplant? Stable without HLH concern is the question, or what conditioning was used, CAMPATH or RATG? And excuse me, because I don't have much medical background, so flu, me, ITT, and current status.
Yeah, thank you, Dr. Evans. That's a great question. So actually, we initially rescheduled the transplant because of the lung functions got worse. And the transplant would be very tricky, that it could increase the mortality risk. So we really focused on the lung rehabilitation to prepare him for that. And eventually, I think starting emapalumab really helped him to control his hyperinflammation. He didn't develop full-blown HLH. Something was protected him from that. Maybe the ruxolitinib or the steroids. But he never had a full-blown HLH issue that was under control. But for that case, emapalumab, I found it helpful to control the hyperinflammation prior to transplant. As of today, his lung functions are slightly better, actually, but it's very, I think, acute setting of transplant right now. Slightly better prior to the transplant. And similar to the heart function is good. And the pericardial effusion already was getting better prior to the transplant and not causing any hemodynamic compromise. So he's stable at room air and can do, regular daily activities. For the regimen, sorry, I should have mentioned that, but it was flu maltiotepa, if I'm correct, and there might be, yeah, I don't remember the CAMPA. There might be there. I need to double check. Sorry. He couldn't tolerate tacrolimus as a GVHD prophylaxis, so we're switching to, again, ruxolitinib for that, for his case.
And did he continue the emapalumab, or did you guys stop that prior to discharge?
He did.
Yeah.
He continued to have still a couple of doses until CXCL9 completely normal.
Oh, okay.
Even
Awesome.
transplant. Mhm.
And that, I assume that was past engraftment then?
Before engraftment even. He received a couple of more doses. So I would say maybe in total he received 4 or 5 weeks of emapalumab.
Okay. And you said you don't yet have engraftment studies, or you do?
It's very acute, but his neutrophils engrafted, platelets are pending, so we haven't
got
reached to the plus 30 day yet.
Okay, very soon. Okay,
Very
awesome.
soon,
Thanks.
yeah. Yes, please, Dr. Payne.
Irem, thanks so much for a great talk. I'm so sorry I missed the very beginning of it. How old is your patient?
18 at initial presentation,
Okay.
19
And
right now.
okay. And I was just curious, so we had a patient that is much older who had a lot of similar stuff. And we also ended up using Ruxo and adding nivolumab for his CAEBV and his TNA and his T cells only, actually. But the problem was he also had a concomitant diagnosis of lymphoma by then. And there was a lot of back and forth about whether or not this was related, whether or not he had maybe underlying lymphoproliferative disease. We don't know because he did not consent to doing any genetic testing. But how does your thinking about transplant and timing change when a person is already actively having cancer?
Mm-hmm. Yeah, that's a great question. And we really had a very close surveillance for our patient to make sure he hasn't had full-blown lymphoma. Um, so I think first controlling the lymphoma part and then eventually preparing for the transplant would be essential, as the disease control prior to transplant will be important. And there are a couple of described choices how to do that in the literature. It was maybe at one of the last slides. But I also now the things might be changing. I was chatting with Dr. Ashish Kumar, like especially the ones who had lymphoma, they are trialing those immune checkpoint inhibitors, incorporating that to the regimen, and maybe first of all avoiding transplant at the first site and see if you could maintain, because as you are suggesting, probably chronic active EBV is driving the lymphoma, but right after transplant, it could be, sorry, right after nivolumab or the chemotherapy agents, it might be tricky to take to transplant right away. And doing, excessive genetic workup, whole genome sequencing, uh, to make sure there is no underlying etiologies. I reach out to PIDTC collaborator from Switzerland who heavily studies ZNFX1 deficiency. I haven't, heard back, but I think they're preparing some series of ZNFX1 new cohort, and they are reporting some of them have chronic active EBV. If the NFX1 is the etiology, prepping him for chronic active EBV, I don't know why it's activated 18-year-old, why he was normal before that is a question. But also maybe giving rituximab kind of prepped him because we were also immune suppressing him meanwhile. Or so there are aging-related alternative splicing or epigenetic mechanisms, who knows, that we still don't know, that activated his disease as a teenage time. And I think paper will be published from Cincinnati group regarding immune checkpoint inhibitors use, and especially at the lymphoma induced by chronic active EBV soon.
Thanks so much.
Are there any further questions for this case? I do want to let everyone know that this was recorded and we can share the recording later. And for if anyone would like to get in contact with Dr. Eldem, please feel free to reach out to me and I can share her contact information with you. Thank you again today for a great case. We hold these monthly patient case conferences every month. If you don't have the main invitation, please reach out to me as well, Evelyn. And we'll see you next time. Thank you everyone for joining today. Great case. Thank you so much.
Thank you.